weight loss and alteration in dietary preferences in humans due to reduced of smell by a novel nasal device varies with age.
So good morning. Thank you, chairpersons. This is my conflict of interest. I am a consultant for the Black Medical who sponsors this trial. So we started with a very clinical question: why, when you have sinusitis or upper respiratory infections, we are less hungry? And we looked into this system and to try to understand why so. So we will know that if we look on the olfactory system, we have the nasal passage, we have the olfactory receptor, and we have the olfactory bulb that you can appreciate that it very much in proximity to the orbital frontal cortex, to the hypothalamus, and to the amygdala. And surprisingly, in the olfactory bulb and mucosa, there's the wealth of receptors of all the orexogenic and anorexogenic signals. And we also know that this relation, this net of connection between olfactory bulb and all the area that controls satiety and appetite is very, very important. So we know that leptin and insulin cause satiety by affecting the POMAC. But we also know that this satiety causes decrease in the olfactory sensitivity. And from this study, we learned that insulin activates this channel, KV1.3. The activation of this channel causes decrease in olfaction. In the case of obesity and diabetes or insulin resistance, there isn't activation of these channels. So the obese and the insulin resistance patients are more sensitive to olfaction. And in this trial, the knockout mice, the KV13 knockout mice, had much higher sensitivity to smell, and they tend to smell the peanut butter much quicker, which not happened in the marble toy. And they concluded that KV knockout mice have 10,000-fold fewer threshold for detection of odors and an increased ability to discriminate between odors. In people, in human beings, this gain of function of this channel causes people to be less or more sensitive to smell and to have higher results or better results in glucose indices. They have lower fasting plasma glucose and lower hemoglobin A1C. And they concluded that we observed that genetic variation, meaning gain of function, in this KV1.3 is associated with decreased olfactory function in healthy humans. Furthermore, we show that olfactory function is dependent on subtle changes in glucose levels. As you see here, the age is very important in smelling, and it was adjusted to age. And the reason for this is that through life, and especially after the age of 50, the smelling capability is decreasing very steeply. Now in Ghrelin, what happened in Ghrelin? We know that Ghrelin because of fasting, the level of Ghrelin is high, that produce higher sensitivity and olfaction that cause us to eat more. And in this study in human being, when they injected intravenously Ghrelin, they increased the capability of smelling, or they increased the sensitivity of smelling. So insulin causes blunting of smelling, and by this maybe cause us to eat less, and Ghrelin increased the sensitivity of smelling and maybe cause us to eat more. And this very recently publication showed that if you ablate the olfactory bulb in mice, you cause those mice that was fed by high-fat diet, you cause them to lose weight and to be much more insulin sensitive. So the aim of our study is to determine if a nasal insert would reduce the ability to smell, reduce body weight, alter dietary preferences, and improve metabolic dysfunction. And for this, we used a randomized single-blinded placebo-controlled study of adults with obesity. And we used this nose-nose apparatus. You can appreciate this apparatus. This apparatus directs air to and bypass the olfactory by decreasing smelling. So you insert this apparatus into the nostril, and it directs the air without the smell. So it's drug-free and it's discreet. We include people between age 18 and 65, BMI 30 to 42. We exclude pregnant women, diabetes, higher blood pressure, thyroid function, and you can see all the exclusion criteria. So we had run-in period, 2 weeks run-in period. In this 2 weeks period, they had to reduce the calorie by 500 calories per day, and they use this apparatus or saline drops. Those who lost at least half a kilo and used the apparatus could enter the trial, which lasts 12 weeks. So the device group wear the device between 5 to 12 hours a day, and the control group used saline drops twice a day. All subjects had less 500 calories per day, and they used food diary and filled food diary. They also filled eating preference and habits questionnaire that was validated according to this study, and we drew their blood in the beginning and the end of the study. In the smelling test, we used the N-butanol, as was described in this study. And the results are. So we had very good randomization. The BMI were 36, very heavy, very obese patients, 50% men and women. The age was around 50, and they didn't have diabetes as was predicted. We had 65 participants that ended the study per protocol, 35 in the study group, in the apparatus, 28 control group, and we showed that the apparatus really significantly decreased the smelling. Of course, the drops didn't do it. The weight. So both groups did lose weight considerably. The study group lost 6.6% weight, and the control group 5.65% of weight. And it wasn't really significantly different. But as you remember, the smelling capability changed after the age of 50. So we divided the group by the age, and now you can appreciate that those who were below the age of 50, meaning the smelling capability is still there, lost 7.7% after 12 weeks, compared to 4.1% those who used the control, the drops. And also you can see the significant difference in BMI terms. So the summary, the whole group didn't have a significant difference, but according to the age below 50, 7.7% compared to 4%. In our surprise, we also found that the smelling ablation really had a great effect on food preferences. And you can appreciate again that those who were less than 50 used much less sugar, much less artificial sweeteners, much less sweet beverage, and much less alcoholic beverage just by using this apparatus. Regarding the insulin level, we did find that there was a significant difference in the device when compared to the end, start to the end. We didn't find a significant difference in insulin level in the control group, and the difference between the two groups were not significant, but a trend too. Remember that those two groups lost the same amount of weight, so it's not the weight that reduced or that increased insulin sensitivity in the device group. And to conclusion, a novel self-administration nasal device that reduced smell caused significant weight loss in subjects below 50 years, reduced dietary preference for sweets, showed a trend in reduced insulin levels without any significant side effects. And I want to conclude with a discussion on this new, very intuitive and very interesting area of olfaction and obesity. Olfaction system and metabolic regulation, there is a close relationship and effect on satiety and hunger, food preferences, and metabolic function. Obesity cause or a consequence of olfactory dysfunction, so we don't really know the answer, but there is evidence for both. The difference between food odor and non-food odor, so people with obesity have increased sensitivity to food odors compared to lean people, and also compared to non-food odors. The effect of olfactory dysfunction on food preferences, so I showed you that yes, mainly reduction in carbohydrate and fattening food. And further study should be conducted to explore this new treatment option and to determine the role of this device for treatment of obesity and diabetes. And by saying that, I want to attention for your attention. I want to thank you for your attention and to thank all the corporate and the people who participate in the study. Thank you.
Thank you very much. Any questions to Dr. Dicker?
Good morning, I'm Raffaella Cancello from Istituto Auxologico in Milano. Thank you for this interesting data and this interesting device. I was wondering if you checked the gustatory threshold in your patient, because it seemed that they change the taste together with the olfaction that are also linked together.
Yeah, very good question. We didn't. We do it in the next. Because it was a pilot study. It's a pilot results. It's really very interesting in new area. So absolutely, taste, it's really smell. Okay? We're not tasting, we are smelling. When we're drinking wine in Italy or in all over the world, we really smell the wine, we don't taste. So of course it's correlates, and we will planning to do it in the next study.
It does work now. Thank you very much for this clear experience. I had a trademark that I developed 4 years ago with the same device. And the problem is that I would like to know how can you fix in the nose, because when we prepare this device was put in the upper part of the nose, because in just in the area where the olfactory nerves arrives, just under the ethmoid and near the upper part of the nose cavity, because the olfactory nerves doesn't cover all the part of the nose. So the problem is that for avoiding any possibly troubles according to the presence of the device, because the problem otorhinolaryngologist express clear suspicion about the possibility to produce infections in this area, which is very, very sensible to bacterial, and moreover the olfactory nerves must be endangered, might be destroyed by the infection. So I would like to know how you can put and fix for a long time in your experience. Thank you very much.
This is the patent, so it's a secret. But we didn't have any infections in our patients.
Thank you, Lessan, UAE. Very interesting, novel idea. I just wondered about your placebo arm. How much of a placebo arm is that? I mean, you know, you're sticking nose drops in, and I know, you know, when I have some drops in my nose, that affects my sense of smell and my food preference probably. And also, if you look at the two arms of the less than 50, so you had 4% weight, was it 4% weight loss? Did I get that right? In your placebo, and 7% weight loss in your active arm. So I'm just wondering if your placebo was more of a placebo, maybe would that be more pronounced, the difference?
Well, it's a good question. When we planned the study, we really don't know what will be the placebo, because you can claim that if you put drops, you made more attention on what you're eating, so like the bracelet, so maybe it's not the placebo, it's the active arm and the apparatus is placebo. When we planned it, we didn't know. Of course, now we are knowing, and the next study would have to be more of a placebo. I agree with this.
I'm assuming it was saline and nasal drops, right? Okay, thank you.
Thank you.